This conference will now be recorded.
So good morning, everyone. Am I audible?
Good morning, sir. Yes, sir.
Alekia?
Yes, sir.
Alekia, are you there?
Yes, sir.
Rohit? Sandeep? Shravani? Am I audible? Right. So today we are going to discuss about NACP 4, that is National AIDS Control Program, 4th phase. So the main goal of this NACP 4 is to halt and reverse the epidemic in India over the next 5 years by integrating programs for prevention, care, support, and treatment. So whatever we have done in the last 3 phases, so we want to integrate all the programs, and we want to halt the spread of the epidemic and reverse the epidemic in India over the next 5 years. For this, what we are doing is we are going to integrate preventive activities, care of the patients, support will be given to the patients, and then treatment will be given to all those who are infected with HIV and AIDS. So the main objective of this program is reduce new infection by 50%. So the main aim is we want to reduce the new infection. So incidence of the cases we want to reduce by 50% to the baseline of NACP 3 and provide care, support, and treatment to all living with HIV/AIDS and treatment service for all those who need it. So for all the people who are infected with HIV, we are going to support them, give them care, support them in all the aspects, and treatment will be provided to each and every infected person. And then all the treatment services will be given to the people infected with HIV and AIDS. So what are the key strategies? So what are the strategies we are going to follow in this program? Is strategy 1 is intensifying and consolidating prevention services. So whatever the services we are providing, we will be intensifying all the services in this NACP 4 and consolidating preventive services. So we will try to consolidate the services which we are providing in the NACP 4. Second one is comprehensive care, support, and treatment. It is a comprehensive care we are going to provide, and support we are going to give, and the treatment services will be given to all the people infected with HIV. And third one is expanding IEC activities. So information, education, and communication activities must be expanded in all the directions, through mass media, through one-to-one contact, through pamphlets, whatever may be the source, whatever may be the through in the colleges, schools, we will approach the teenagers, colleges, schools, and in the form of all the in all forms of media, we will be focusing about the HIV/AIDS program, so that the people will get aware about this HIV and AIDS, its modes of transmission, its prevention, its treatments, what are the treatments available, everything the people must come to know about them. And strengthening institutional capacity. At the same time, we need to strengthen the capacity of the institutes. So infrastructure wise, manpower wise, we have to strengthen the institutions, so that they can provide the appropriate services to the people infected with HIV and AIDS. And strategic information management system. So information collection, and then right information must reach the people in the right time. Then only they will understand the message properly, they understand the information properly, and act according to the information whatever provided by you. So strengthening of information management system is also most important. So the important strategy in this NACP 4. So these are the key strategies which we are going to follow in NACP 4. Number one is intensifying and consolidating preventive services, comprehensive care, support and treatment, and expanding IEC activities, strengthening institutional capacity, strategic information and management system. If you look at the package of services, like prevention services, so what are the preventive services which we are going to provide under NACP 4? Like targeted interventions for high risk groups and rich populations. So you can see it, high risk group are nothing but especially for HIV/AIDS, that is prostitutes, men having sex with men, intravenous drug users, transgenders or Hijra population, right? So these are the main people, these are the main targeted high risk population for this disease, and the bridge population. Then needle syringe exchange program and opioid substitution therapy for IDUs. IDU means intravenous drug users. So for them, what we are, instead of drugs, we are starting opioid substitution therapy we are going to provide them. And then prevention interventions for migrant population at source, transit and destination. So people who are migrating from one place to another place, so for them also we are going to provide the preventive interventions. And link worker scheme for high risk groups and vulnerable population in rural areas, prevention and control of sexually transmitted infections and reproductive tract infections. So we are going to prevent and control sexually transmitted infections like gonorrheal diseases, or any discharge from the urethra, or whatever it may be. All sorts of signs and symptoms related to sexually transmitted diseases, we are going to control them. And at the same time, reproductive tract infections, so those people are more prone for HIV. That's why we are going to give utmost care to all the people suffering with STIs and RTIs. And then blood safety, it is also most important. So we are going to take care of the blood safely. Like we are not going to collect the blood from the routine people, those who are giving blood routinely. So we are going to screen them properly. We are going to screen the individual properly and screen the blood also properly, so that there should not be any infection spread through the blood. Then HIV counseling and testing centers. So ICTCs and VCTCs we are going to establish. So through them we are going to counsel the cases, and we are going to support them through ICTC and VCTCs. And then PPTCT, that is prevention of parent to child transmission, also we are going to take care of. Then condom promotion by social marketing, we are going to provide condoms freely to, we are going to charge very little, but at the most we are going to provide them freely, all condoms to. And then IEC and BCC, that is information, education and communication, will be provided to all the people in the society. And behavior change communication we are going to bring. And then social mobilization, youth interventions and adolescent education programs. That is, adolescent education programs are nothing but like a school AIDS talk program, we will go to the schools and educate them about the HIV and AIDS, especially in the colleges. So where about this AIDS, we will keep a seminar or a workshop or a group discussions like that, so that the students will get educated about the HIV and AIDS. That is adolescent education program. And mainstreaming of HIV/AIDS workplace interventions. So these are all the preventive services which we are going to start in the NACP 4 program. So care, support and treatment services. So what we are going to provide under this care, support and treatment services, that is lab services for CD4 testing and other investigations. So whatever the investigations, like you see in HIV case, because of lack of immunity, there will be opportunistic infections will be there. So n number of opportunity infections will be there among the HIV cases. So in that scenario, what we will do is, we will go for investigations. So main is CD4 count. So we will be doing CD4 count, and with that we will do all the other investigations which are necessary for that particular case. So first line, free first line and second line ART. So at the same time, treatment also will be given free of cost. That is first line treatment and second line treatment. Treatment will be given. That is antiretroviral treatment. So pediatric ART for children. So especially pediatric ART also we have started. Early infant diagnosis for HIV exposed infants and children below 18 months. So for infants also we have started giving treatment. Preventive services we are going to give for the early infant. So for diagnosis of HIV exposed infants and children below 18 months. Nutritional and psychosocial supports through care and support centers. So nutrition as well as psychosocial support will be given to the parents. HIV TB coordination, that is cross referral, detection and treatment of co-infection. So once the patient is infected with HIV, there is a chance of because of low immunity, there is a chance of getting tuberculosis. So we are going to test that also. We are going to investigate for tuberculosis also. And if at all if he is positive for TB, then he will be getting treatment for tuberculosis along with HIV. Treatment of opportunistic infections. So I told you already, opportunistic infections will be plenty. So for all those opportunistic infections, we will screen, we will do the investigations, and we will start the treatment. So drop-in centers for PLHIV networks. If you look at the country scenario, classification of states. So how the states are classified based on the prevalence, especially among the high risk group and antenatal cases. Suppose if the prevalence is more than 5% in high risk groups. So I told you high risk groups means transgenders, men having sex with men, then prostitutes, and intra-drug users, and then truck drivers. So these are all the high risk groups. So among them, if the prevalence is more than 5% and more than 1% in antenatal cases. Suppose if the prevalence is more than 1% in antenatal cases, so it is considered as high risk state or high prevalence state. So among them, the states having more than 5% in high risk group and more than 1% in antenatal group, that is Maharashtra, Tamil Nadu, Andhra. So our Andhra Pradesh is in high prevalence group, and then Manipur, Karnataka and Nagaland. So these are the states which are having more than 5% in high risk group and more than 1% in antenatal cases. If you look at the moderate prevalence, so if you look at the moderate prevalence, if the HIV prevalence is more than 5% in high risk group and less than 1% in antenatal category or antenatal cases, then it is considered as moderate prevalence states, which are Gujarat, Pondicherry and Goa. See, moderate prevalence states which consists of more than 5% in high risk category and less than 1% in antenatal category. So the states which come under this moderate prevalence category were Gujarat, Pondicherry and Goa. And if you look at the low prevalence states where the prevalence was less than 5% in high risk group and less than 1% in antenatal cases, so all other states and union territories, so whatever the states are remaining and union territories are there, they will come under low prevalence prevalence category. That means the prevalence of HIV is less than 5% in high risk groups and less than 1% in antenatal cases. So they will come under low prevalence category states or union territories. If you look at the classification of districts, so that is for classification of states. Whereas if you look at the classification of districts, so districts are classified into 4 categories, that is from A to D. So category A comes under more than 1% antenatal or PTCT prevalence, that is parent to child transmission prevalence in district in any of the sites in the last 3 years. Suppose if the prevalence is more than 1% in antenatal or PPT-CT prevalence in any district in any of the sites in the last 3 years, then it comes under category A. Then if you look at the category B, less than 1% antenatal or PPT-CT prevalence in all the sites during the last 3 years with more than 5% prevalence in any high risk group site, that is sexually transmitted diseases or female sex workers, men having sex with men or intravenous drug users. Among these sites, if the prevalence is more than 5%, then it comes under category B. Then if you look at the category C, less than 1% antenatal prevalence in all the sites during the last 3 years with less than 5% in all high risk group sites with known hotspots, that is migrants, truckers, large aggregation of factory workers, tourists, etc. And if you look at the category D, less than 1% ANC prevalence in all the sites during the last 3 years with less than 5% in all high risk group sites with no known hotspots or no or poor HIV data. So this is a classification of district, that is 4 types, that is A to D. It is based on the prevalence among the ANC or PTCT for the last 3 years. So based on that, they have divided the districts into categories, that is category A, category B, category C, and category D. If you look at the HIV surveillance is nothing but identifying the risk factors, identifying the factors responsible for causing the disease. So the continuous scrutiny of the factors which causes the disease in the society, if you are monitoring them, then it is called surveillance. So surveillances are being carried out to detect the spread of the disease and to make appropriate strategy for prevention and control. That is by area specific targeted interventions and best practice approach. So if you look at the different types of HIV surveillances, you can see HIV sentinel surveillance is there, HIV zero surveillance is there, AIDS care surveillance is there, STD surveillance is there, behavioral surveillance is there, integration with surveillance of other diseases like TB. So these are the different types of surveillances: HIV sentinel surveillance, HIV zero surveillance, AIDS case surveillance, STD surveillance, behavioral surveillance, integration with surveillance of other diseases like TB, etc. Out of the above, most effective one is the HIV sentinel surveillance. The main aim of the surveillance is to confine to monitor the trend of the HIV infection. So the main aim of this surveillance is we want to see how the trend of this HIV is going on in the society. So among the high risk groups, how the trend is there, and among the normal population, how the trend is there. So we want to monitor the trend of this epidemic in the society. That's why we are doing this surveillance activity. So what are the objectives of this surveillance? So to determine the level of HIV infection among general population as well as high risk groups in different states. So we want to know how this epidemic is progressing, whether among the general population as well as the high risk group. So what is the difference? Whether suppose if among the high risk group, if the prevalence or the incidence of the disease is going up, or if the graph is going up in the high risk group, so definitely we need to strategize properly. We need to devise new mechanisms to halt the spread of the disease, to halt the progress of the disease among the high risk category. So what are the preventive strategies we have to plan among the high risk group? So we can plan accordingly as per the increase in the graph. We are going to apply the preventive strategies so that we will try to reduce the incidence of the disease among the high risk group. Suppose if the graph is increasing among the general population, then we have to be very careful. Because among the general population, if the graph is increasing day by day, so we need to strategize exactly or correctly, so that we need to stop the spread of the disease among the general population. So we have to frame another sort of strategic strategies, so that we need to stop the spread of the disease among the general population. So we want to know the difference, whether in the general population the rise is more, or in the high risk group the rise is more. So among which group there is a high rise is there, we want to identify. So that's why to determine the level of HIV infection among general population as well as high risk group in different states, and then to understand the trend of HIV epidemic, among general population as well as high risk groups in different states. So among the different states, what is the trend among the high risk group? As at the same time, what is the trend among the general population? We want to identify. To understand the geographical spread of infection and to identify emerging pockets. So geographically, that means throughout India, how the disease is spreading. How the disease is spreading. So among which state it is high? Among the different states, which state the increase is very high? And what are the reasons for that? What are the reasons for that? You need to study the reasons and you need to plan the preventive strategies for the particular state separately. So that's why we need to understand the geographical spread of the infection and to identify emerging pockets. To provide information for prioritizing of the program resources and evaluation of the program impact. So every time you need to get feedback information from the from different areas, and you have to analyze the information and see how the program is going on. What is the impact of the program? What is the impact of our program on this particular disease? We have to know it. To estimate prevalence and HIV burden in the country, it is done in the same place over a few years by anonymous serological testing. HIV testing is done without identification of name of samples collected for other purposes, example VDRL, STD clinics. So those people who are coming to VDRL, that is for any problem, any sexually transmitted diseases, infection, STDs or reproductive tract infections. So among them, we are going to do the HIV testing, and for the STD clinics also. So the demerit of this is that the positive person is not identified. So here what we are doing is, for the sake of confidentiality, we are not exposing the name of the person or the phone number or name or something like that. We cannot expose the person. So because of the confidentiality, we cannot identify the person who identify the positive person. That is the demerit of this one. So in 1994, it was started with 55 sentinel sites and became 180 in 1998. The number of high risk group of people increased with increase in HIV sentinel sites. So as among the high risk group only, the HIV has been increased at different sentinel sites. What are the key features of this surveillance are inclusion of data from high risk population through targeted intervention sites, adding rural samples through antenatal clinics. So the main advantage of this surveillance is we are going to take data from the high risk population, as well as we are going to collect the data from rural samples from the antenatal clinics. The strategy adopted was, whatever be the sentinel site and the amount of sample collected, the duration, frequency and age group of the people in the surveillance should be the same in all the high risk groups, bridge population and general population. So these are the different sites. You can see high risk groups, that is the IDU, MSM, FSW, transgenders. So bridge population means STD patients, long truck drivers, so HIV sentinel surveillance around 2010 to 2011, you can see high risk group, intravenous drug users, men having sex with men, female sex workers, transgenders, whereas the bridge population means STD patients and men, females, SMM, then LDT, that is long truck drivers, long distance truck drivers, and you can see general population, that is pregnant women attending antenatal clinics. So these are the sites, sentinel sites, sample size 250 and 400, duration 4 months, frequency once in 2 years, once in 2 years, once in 2 years, sampling method consecutive, random, consecutive, age group 15 to 49. So all are equal age group, unlinked, anonymous and informed consent, dried blood spot, two test protocol. So these are the sentinel surveillance rounds where they have taken from different groups, that is high risk group, bridge population and general population. Then counseling and HIV testing services. So these services started in India since 1997. The components of ICTC: prevention of parent to child transmission of HIV, HIV-TB collaborative activities. So these are the components of counseling and HIV testing services. Number one is ICTC, integrated counseling and testing centers. Second one is prevention of parent to child transmission of HIV. And third one is HIV or TB collaborative activities. So what is this ICTC, integrated counseling and testing centers? This is available to increase access to HIV diagnosis. It includes testing services and community approaches at various levels of the health system in India, like state, district, sub-district, and village community levels. So what are the functions of this ICTC? You can see early detection of HIV. So it is an access for all the people in the society. They can go to the ICTC voluntarily. They can represent themselves to the ICTC and they can ask for and they want to undergo HIV testing and counseling. So definitely they will do that. That is so that you can be identified at the early stage, so that proper treatment and proper preventive strategies and proper treatment will be given to you. So provision of basic information on modes of transmission, prevention of HIV for promoting behavioral change and reducing vulnerability, linking to PLHIV to care, support and treatment. So what are the main functions of this is, so promoting behavior change. So if you are having any sort of behavior, so your behavior will be modified, promoting behavioral change and reducing vulnerability and linking to PLHI to care, support and treatment. So what they do is they will try to modify your behavior and they will try to attach yourself to the link worker will be there. So that worker will take care of you. They will support you. That worker will support you in all the aspects. Psychological support will be given, and the treatment services where available. They will provide all the types of treatments which are available to the nearest. So what are the types of ICTC? So there are two different types of ICTC are there. That is the fixed facility ICTC and second one is mobile ICTC. So fixed facility ICTC are located within an existing healthcare facility, that is hospital or healthcare center, are of two types, that is standalone ICTC and facility integrated ICTC. Standalone ICTC, the client load is high in the center with full-time counselor and lab technician who provide HIV counseling and testing services. So standalone means especially in medical colleges, and health centers where the patient load is very high. So in those areas they are going to keep a fixed facility. Fixed facility will be there where standard counselor will be there and he will be doing all the services. He will be doing the testing, HIV counseling and lab technician who provide HIV counseling and testing services. So fixed facility, fixed ICTC, these are set below the block level in 24/7 PHCs. Staffs are trained in counseling and testing services of HIV. Similar to this, public-private partnership. So public-private partnership with the ICTCs are also established. So these centers are supported by SACS and District AIDS Control Society. And the mobile ICTCs are available. That is, the main aim is a van with a room to conduct general examination. They will do counseling and collection and processing of blood and blood products. They are set in hard to reach areas as temporary clinics. They also provide counseling and services about regular health checkup, antenatal checkup and immunization. So van is modified into a room. So in that they will do counseling and they will collect the blood. They will do normal health checkups, antenatal checkups and immunization also they will do in that van. Then community based. So mainly the main aim of this mobile ICTC is they want to reach to the unaccessed areas. So maybe rural areas or tribal areas where the healthcare facilities are very poor. So for those type of people, so this mobile ICTCs are more useful. So these mobile vans, they will go into the unaccessed areas and they will conduct HIV testing and counseling among those unaccessed people, underprivileged and unaccessed people, and they will do the health checkups, immunizations. They will do antenatal care, antenatal checkups, immunizations, and HIV testing and counseling. And community-based HIV screening is done by ANM at subcenter level to provide HIV testing to all the pregnant women. It is done to prevent transmission of HIV from parent to child. So all these activities, so mobile ICTCs, so they have came up with two types of ICTCs, that is fixed facilities, fixed ICTUs, and mobile ICTC. Fixed facilities will be there at the district hospitals and teaching hospitals, whereas the mobile ICTCs will be there. So the which will reach to the unreached population, unreached or unaccessed population. Among them, they will conduct HIV testing and counseling. They will do immunization services. They will do the checkups, health checkups, antenatal checkups. They will do so, and HIV testing and counseling. So these are the different types of ICTCs which you have to keep in mind. And if you look at the level of HIV counseling and testing services in India, you can see state and district level, medical colleges and district hospitals, that is standalone ICTs. I told you, so because the patient load, the state and district level hospitals, patient load will be heavy. So we need a fixed facility where we need to have lab testing services and the counselor to counsel the patients coming to the ICTCs, that is standalone ICTCs at the district hospitals as well as the medical colleges. And second one is sub-district level, that is civil hospitals and community health centers, standalone ICTCs and facility ICTCs. The village level, you can see primary health centers, 24/7 PHCs, private hospitals, labs and NGOs, standalone ICTCs and facility ICTCs. And at the community level, HIV screening using whole blood finger prick test, mobile ICTCs reaching vulnerable or high risk groups, unreached population. So community level HIV screening using whole blood finger prick test, mobile ICTCs reaching vulnerable high risk groups, unreached population. So these are the different levels. So from top to bottom, if you go from the district to sub-district to village level, and front to the community level. So different levels are there. So based on the level, we have to select what type of ICTC you have to establish and what are the services they have to provide. And prevention of parent to child transmission of HIV. So the prevention of parent to child transmission of HIV/AIDS PPTCT program was started in 2002. Currently, there are more than 1500 ICTCs in the country which offer PPTC services to pregnant women. The main aim of this program is to do HIV testing to every pregnant woman in the country so as to cover all estimated HIV positive pregnant women and eliminate transmission of HIV from mother to child. So the main aim of this PPTCT or prevention of parent to child transmission is to conduct HIV testing, is to offer HIV testing to every pregnant woman. So see here, what you have to do is all the pregnant women you have to conduct the HIV testing, but at the same time it is not mandatory. Suppose if a female is there, instead of your repeated counselings, if she is not interested to undergo HIV testing, we cannot do anything. We cannot force anybody, or we cannot do HIV testing forcibly on anybody. Without their consent, we cannot conduct HIV testing on anybody. This is the most important point which you have to keep in mind. So the main aim of this program, see how they have written, the main aim of this PPTCT program is to offer HIV testing to every pregnant woman. We need to offer it. They may accept it or they may reject it, but we need to counsel them periodically, repeatedly, by explaining the importance of doing HIV testing and the advantages and disadvantages of not undergoing this HIV testing, what are the advantages and what are the disadvantages? We have to explain to the pregnant woman repeatedly to her antenatal visits, and you have to make them realize the importance of HIV testing and ask them to undergo that test. But forcibly, you cannot force any antenatal case to undergo HIV testing. So we need to counsel them repeatedly. Every time you send her to the HIV ICTC center and ask her PPTCT center and ask her to undergo HIV testing. So there the counselor will try to handle her properly, explain the modes of transmission, the benefits, and then what are the treatments available. So what are the advantages and disadvantages? Everything he will be explaining to that antenatal case, so that at one point of time she will agree and she will undergo HIV testing. But you cannot force anybody to undergo HIV testing, or forcefully, or without the notice, of her. Like you take the blood and you will do it unknowingly. If you do that, it is a wrong and it is crime. You will be punishable. So you have to take the consent of that particular person and you have to conduct the test. So without consent, you cannot do HIV testing. That's why they have written, you have to offer HIV testing to every pregnant woman in the country, so as to cover all estimated HIV positive pregnant women and eliminate transmission of HIV from mother to child. So in India, PPT-CT interventions under NACP was started in 2002 using standard nevirapine prophylaxis for HIV positive pregnant women during labor and also for her newborn child immediately after birth. So under this PPT-CT, what they have done is, if a mother is, if any pregnant or antenatal is identified as positive, so she will be followed up, and at the time of delivery or at the time of labor pains, she will be given nevirapine, that is a standard dose for the mother, so that to prevent the transmission of HIV from parent to child. And for the newborn also, for prophylaxis, nevirapine will be given. So this is when they started in 2002. So again, not only that, so in 2010, what they have done is they have gone for option B, that is from single dose, World Health Organization, what they have done, from single dose nevirapine strategy to that of multi-drug ARV prophylaxis from September 2012. So not only for nevirapine into September 12, so antiretroviral drugs are available. So they have started multi-drug ARV prophylaxis from September 2012. So this PPT services using multi-drug ARV in India was developed in May-June 2013 for nationwide implementation in a phased manner. So the PPTC services provide access to all pregnant women for HIV diagnostic, prevention, care and treatment services. So under this PPTCT, they are going to provide diagnostic services, prevention services, care and treatment services. So these are the 4 components of PPTCT, that is diagnostic, prevention, care and treatment services will be given under PPTCT. And then HIV TB collaborative activities. So you can see, so those people who are having HIV, they may be infected with HIV, tuberculosis also. So in that scenario, so they will be tested, they will undergo testing for tuberculosis also. If they are found positive, then they will be start tuberculosis treatment. So they will start tuberculosis treatment, and after that they will give antiretroviral treatment also. You can see prevention. So for them, isoniazid preventive treatment will be given, airborne infection control and awareness generation, early detection of TB or HIV, 100% coverage of in TB patients. In presumptive tuberculosis cases, rapid diagnostics for detection of TB and drug-resistant tuberculosis in patients living with HIV. So in all this, prompt treatment of TB or HIV, management of specific TB or HIV. So these are all the activities coordination to reduce mortality. So care, support and treatment. So the CST component of NACP aims to provide comprehensive services to people living with HIV with respect to free antiretroviral therapy, psychosocial support. So whatever the treatment is needed by that particular person, it will be provided free of cost. And then psychosocial support, majority of the people, they will end up with depression and finally they will commit suicide. And some people, they will become psychos, and some people, they will become very mad at that they want to spread the disease to the entire society. So they will be doing all antisocial activities in the society. So for them, the need of the hour is psychosocial support is needed. So counseling, periodical counseling and behavior change is most important among those HIV positive cases. So that also they are going to support. So prevention and treatment of opportunistic infections, including tuberculosis. So you can see so many like fungal infections are most common. Respiratory tract infections, GE infestations, fungal infections, most common among these HIV cases, including tuberculosis. And facilitating home-based care and impact mitigation. These are all the things which come under the care and support. You can see the services provided provided at the care support centers. You can see model of HIV treatment services. You can see at the sub-district level, district level hospitals and CSCs, link ART centers and LAC plus centers. The medical college and district level hospitals, ART centers will be there, antiretroviral centers will be there. So they will distribute the treatment. And then center of excellence and ART plus selected medical colleges. You can see here. So altogether, right now in India, ART centers 519, link ART centers 1073, center of excellence 10, pediatric center of excellence 7, antiretroviral treatment plus centers 52, care support and treatment centers 350. So these are the right now, these are the institutions which are providing care support and treatment services in India. So antiretroviral services provided, that is antiretroviral therapy. So first line ART provided free of cost to PLHIV through ART centers. So all the centers, they will provide free of cost treatment, and so for them, so inpatient, so they will provide treatment as well as nutrition also they will provide, and counseling will be given. Follow-up is done by assessing drug adherence, regularity of visit, periodic examination, and CD4 count testing in every 6 months. So they will see how the patient is taking the drug, how the adherence is there, regularity of visit. So how whether he is visiting the clinic regularly or not, periodical examination, and CD4 counts every 6 months. They are going to measure the level of CD4 count. Till 2017. 7.68 lakh PLHIV were there on first line ART. See, 2017, 7.68 lakh PLHIV were on first line ART. After launching of pediatric HIV/AIDS initiative till March 2017, you can see 1 lakh 68 6,824 cases were registered, and out of that 42,015 are on first line ART. So there are alternate first line ART also there. So it has been observed that a small number of patients initiated on first line ART experience acute or chronic toxicity intolerance to first line antiretroviral drugs, thus necessitating change of ARV drugs to alternate first line drugs. Presently, the provision of alternative first line ART is done through the centers of excellence and ART plus centers across the country. So if at all some people get any toxicity or any adverse events or any complications, so for them they will be admitted, treated, and then there is alteration in the first line ART. So change of ARV drugs to alternate first line drugs. So the provision of alternate first line ART is done through the centers of excellence and ART plus centers across the country. So through this centers of excellence, they will provide alternate first line ART if at all they are having any complications or adverse events with the first line ART. So second line ART. So some ART centers were upgraded to plus centers. All ART centers are linked to Center of Excellence, ART plus centers. This panel meets once in a week for taking decisions on patients referred to them with treatment failure or major side effects. So this is about the pediatric HIV/AIDS initiative. So targeted interventions for high risk groups. The main objective of targeted interventions is to improve health seeking behavior of high risk groups and to reduce their risk of acquiring sexually transmitted infections and HIV infections. So targeted interventions for high risk group means we need to identify the high risk group and their behavior. So we have to change their behavior. So high risk groups are mainly female, mainly prostitutes, men having sex with men, and then intravenous drug users, transgenders. So these are the high risk population, and long distance truckers. So these are the high risk population. We need to identify them and try to modify their behavior, health seeking behavior you have to modify, and reduce the risk of acquiring sexually transmitted infections and HIV infections. The services offered through targeted interventions include. So what are the services we are going to provide for this targeted high risk group? We are going to detect and treatment for sexually transmitted infections. So for STDs, we are going to detect the STDs early and we are going to treat them early. Condom distribution, it may be through social marketing. It may be through social marketing or through free distribution. Condom promotion through social marketing. Behavior change communication, we need to bring the change in the behavior of this high risk group. So we need to create an environment in the community so that the people must come forward and utilize the services whatever we are going to provide. So the community has to participate in these programs and see that they create an awareness in the society about the HIV and AIDS. So we need to link this to the integrated counseling and testing centers, linkages with care and support services for HIV, and then high risk groups, community organization and ownership building. These are the services that are offered to the targeted interventions. Specific interventions for IDU, that is intravenous drug users. So what we have to do is distribution of clean needles and syringes. So we need to stop them as early as possible. But if it is not possible at once, we cannot do that. Slowly we have to reduce. So distribution of clean needles and syringes must be provided. Abscess prevention and management. Opioid substitution therapy. So instead of needles, drug addicts, so we have to give them opioids, and then linkage with the detoxification and rehabilitation services. So we have to link with detoxification as well as rehabilitation services for IDUs. Specific interventions for men having sex with men and transgender, that is provision of lubricants. Special interventions for transgenders for Hijra population. Provision of project-based STI clinics. Provision of project-based STI clinics. And there is another scheme that is called as link worker scheme. So mainly this link worker is mainly what he will do is they will provide care, support, treatment. They will provide care, support, treatment services to all the people living with HIV and AIDS in especially remote areas or in the villages. Community-based outreach strategy to address HIV prevention and care needs of high-risk group and vulnerable population in rural areas. So the main objective of this is to reach out the groups with information and knowledge on prevention and reduction of HIV and STD, condom promotion and distribution, providing referral follow-up linkages for various services. So the main objective of this link worker scheme is they will create awareness in the unreached population, then condom promotion, testing about the condom promotion, distribution, providing referral services and follow-up linkages. So they will create an environment among the PLHIV and they will try to reduce the discrimination and stigma in the society, and they will get partnership with various developmental partners. The link worker scheme has been expanded and is being implemented in 17 states. And then coming to blood transfusion services. So if you look at the blood transfusion services, only licensed blood banks are permitted to operate in country, and voluntary blood donation is encouraged since 1st January 1998. So previously, repeatedly people are going and giving the blood, and maybe they may be addicted, they may be drug users for the sake of money. So many people are donating blood repeatedly, and they are though they are having some sort of diseases. So what we under this policy, what we have done is, only people will come and the licensed blood banks are going to collect the blood, and the people has to come voluntarily to donate the blood is encouraged. And the strategy is safe collection, processing, storage and distribution of blood and blood products. Zonal blood testing centers have been established to provide linkage with other blood banks. So with other blood banks also there is a linkage, and all the blood which is collected, they are going to test for HIV, hepatitis B, hepatitis C, malaria and syphilis. And the NACO is supporting. And now right now we are having 34 model blood banks, 260 major blood banks and 613 distinct level blood banks. And we are having blood storage centers were established in first referral units at sub-district level for wider availability of safe blood, particularly for emergency, obstetric care and trauma care services. So I will stop here. 121. Roll number 100. Roll number 100.
Yes, sir.
Roll number 121. Roll number 1.
Present, sir. One
Roll
present,
number
sir.
Roll number 99. Roll number 5.
Present, sir.
Okay. So I will stop here. Thank you everyone.